Today, I'm going to discuss a case where we had both constrictive pericarditis and atrial septal defect. And this is not a good combination to have because we have seen many a times that in case you have a CCP, you tend to miss ASD because the pressure in LA and RA are same. And in case you have an ASD, we tend to miss constrictive pericarditis because many of the features of constriction are lost because of the free flow of blood between the two atria, right? So I think it's a good idea to subscribe because I would keep on posting something interesting like this, and I think it would be good learning. So do subscribe. I'm just highlighting this young man who came with a history of dyspnea, and he had JVP elevation, and there was a pedal edema, and there was a murmur and a fixed split of an S2. So we did an echo, and echo showed the large atrial septal defect, and there was flow across the interatrial septum. So this was an ASD, right? Okay. So there's certain things which are not being explained by the ASD. One was this JVP. We saw this JVP elevation, and if you notice, the JVP level is somewhere here, and you see a very rapid Y descent, and that rapid Y descent is many people call it Friedrich's sign. So JVP elevation in atrial septal defect is pretty uncommon. It cannot happen. It can happen in three ways. Way number one, if the LVEDP is elevated, so LA pressure is transmitted into RA pressure, and then you have an elevation of JVP. Two is that you have an RV pressure which is elevated, and there is an RV, the LVED, RVED increases, RA pressure increase. And in this situation, more likely would be that there would be a right to left shunt rather than increase in JVP. Third situation could be a combination of both. There is an LVEDP increase, there is an RVEDP increase, condition like constrictive pericarditis, right? Additional parameter apart from the elevated JVP in this patient was pedal edema, again not explained by the ASD. So with this, we had a suspicion that this patient had constriction. We went ahead and proved that, and you can see there is a septal bounce very clearly on the left parasternal view, and even on a short axis view, you can see a septal bounce on interventricular septum. We did not get a usual inflow velocity variations because of inspiration and expiration in CCP, which is quite understandable because the variations are obtended by the change of the blood flow in the atrial septal defect because of the equalization of pressures in LA and RA because of an ASD, and you don't go get those respiratory phasic variations on constrictive pericarditis. So here one can miss constrictive pericarditis because there is no variation with the respiration. Similarly, there wasn't any variation or respiration in the inferior vena cava, in the pulmonary venous system, but we did have a very large E prime on a lateral annulus, which is a kind of a sign for CCP. And the other signs of CCP did persist. There was a septal bounce, and one could see some thickening of the right ventricle or the pericardium across the right ventricle. And this is it's not a very sensitive sign, but if present, it is fairly specific. What happens actually with the respiratory variations? The intrathoracic pressure is affected on pulmonary veins, it is affected on RA and LA, but it's not affected on the superior vena cava and inferior vena cava. What happens in inspiration? The pulmonary vein also get the slight dip in the pressure because of the negative pressure of the lungs. Intrathoracic pressure also affects RA and LA and reduces 5 millimeter of pressure, and that happens in inspiration. Both LA and pressure, the gradient remains the same and there is no change in the flow, right? But In CCP, now there is a fall in the pulmonary venous pressure because of a fall in intrathoracic pressure, but the constriction or the thickening of the pericardium does not allow the inspiratory effect to be present on the RA and LA. This leads to reduction in left atrial inflow and thus causing an respiratory variation. What are the signs which actually tend to be lost in CCP if we have a coexistent atrial septal defect? The Kussmaul sign, again based on the respiratory variation, is gone. Pulsus paradoxus based on respiratory variation is gone, and almost all the signs of respiratory variation are gone. Understandably, because if there is a reduction in LA inflow, and this would be compensated through an ASD because there is a free communication between LA and RA. The signs which are persisting, even if there is an ASD or no ASD, is a JVP elevation. Friedrich sign is there. Pericardial knock one can hear. One sees a septal bounce like we saw in our case. You have a flat posterior motion of LV wall, which we again saw in one of that patients, and IVC is dilated. But again, no respiratory variations. The annulus paradoxus, that the lateral annulus is smaller and medial is larger in CCP with the large E prime, again suggests CCP. So it reminds me of a common saying that which is the common abnormality missed? That usually is the second one. You picked up an ASD and you don't look at anything else and you can miss a CCP. You make the diagnosis of CCP and you may ignore the presence of an ASD, so the second one can be easily missed. There has been case reports of missing a constrictive pericarditis in presence of an ASD. So it is important whenever you have certain signs or symptoms like raised JVP, pedal edema in this case, consider CCP in presence of atrial septal defect. And I must thank you guys because many of you are already subscribed to my channel, and I hope you are getting the inputs whenever my next video comes. You are informed about it. So keep looking at that, keep subscribing, and keep learning. Thank you very much.